Hi, everyone, and welcome to the February edition of Hot Topics and Acute Pain and Regional Anesthesia Edition. As always, I'm your host, Jaime Baratta, and today we have a fantastic panel speaking about optimizing acute pain management with advanced multimodal analgesics. Now, our first speaker is Dr. Jeffrey Mojica, who is an assistant professor at Thomas Jefferson University and the medical director of the Jefferson Pain Center at Methodist. He is fellowship trained in both regional anesthesia, acute pain, and pain management. He'll be speaking about the value of ketamine in acute pain management. Our second speaker is Dr. John Paul Pozek. Dr. Pozek is an associate professor at the University of Kansas Health System and director of the acute pain service. He is fellowship trained in regional anesthesia and acute pain medicine. And he'll be speaking about optimizing acute pain with lidocaine infusions. And our final speaker is Dr. Gary Schwartz. Dr. Gary Schwartz serves as the Director of Acute Pain Management and Co-Director of Pain Management for AABP, LLP, and Maimonides Medical Center. He is also fellowship trained in pain management and serves on numerous ASRA committees. And he will be speaking on additional multimodal analgesics for your acute pain toolbox. Now, if you have any questions, please type your question in the small Q&A box at the bottom of the screen, and when finished, click send. At the end of the presentation, we'll have about 10 to 15 minutes to have a good discussion about multimodal analgesia. Please note, due to time constraints, we may not respond to all of the questions submitted, but any unanswered questions can be posted to our speakers on Twitter or on the ASRA Hot Topics site. And now I'm going to go ahead and turn it over to our first speaker, Dr. Mojica.
Thanks, Jamie, Dr. Baratta. All right, let me just start sharing. All right, can you guys see me? Is everything okay? Take the silence out. All right, great. So as Dr. Baratta mentioned, I'll be discussing the value of ketamine in the management of acute pain. I have no relevant financial disclosures. These are my objectives. I'll be briefly discussing the ketamine pharmacology. Then I'll be talking about the acute pain conditions that are most suitable for ketamine and how to safely administer this medication. So in recent years, the use of ketamine seems to have exploded. Aside from being a pretty well-known party drug and an animal tranquilizer, the use of ketamine has really become popularized for various psychiatric and chronic pain disorders. The same is also true for the use of ketamine for acute pain-related issues. And this is largely due to the opioid epidemic. We know that acute opioid exposure following surgery is a known risk factor for new persistent opioid use, and non-opioid multimodal analgesics has really been emphasized as a strategy to reduce our reliance on perioperative opioids. So many acute pain services and acute pain physicians, they really turn to one of our oldest anesthetics and analgesics, and ketamine. So we know that ketamine has a very complex pharmacologic profile. We know that it possesses analgesic properties, it has antidepressant properties, it can help regulate our mood, and also has psychiatric psychomimetic effects. And we also know that a lot of these effects are largely mediated by antagonism of the NMDA receptor. We also know that the NMDA receptors are located in the areas of the brain and spinal cord and CNS where that largely correspond to the pain pathway. So if we think about the 5 major steps in the pain pathway, which are transduction, peripheral transmission, central transmission, perception, modulation, ketamine is really involved in 3 out of these 5 major processes. So from a neuropharmacological standpoint, ketamine really has a diverse pain medication profile that targets the pain pathways several different ways. So since the use of ketamine for various acute chronic pain and psychiatric disorders has really exploded, in 2018, ASRA came up with ketamine guidelines for acute pain and also for chronic pain. The ones I have here listed on the sheet on my slide is the acute pain guidelines. For those of you who haven't read it, I do highly recommend it. It's a great paper, but for the sake of time, I'm really only going to be focusing on these three points that we have here. The patients that could benefit, what conditions, how we dose it in the acute pain setting, and where and how to really infuse this so that you can deliver a safe sub-anesthetic analgesic dose of medication. So overall, the acute pain conditions or the patients that could benefit and the acute pain conditions that could that are most suitable for ketamine is really the big question that the paper addresses. And it comes down to four topics here. It's there are surgical patients that are undergoing moderate to severe intensity, our opioid tolerant patients, and then our opioid tolerant non-surgical patients, and lastly, our populations at risk for opioid related adverse events. I break this down a little bit further into two separate groups. There are surgical and our non-surgical patients. So according to the guidelines, the patients undergoing the most painful of surgical procedures, this includes our orthopedic surgeries, our spine surgeries, amputation surgeries, and upper, and really the abdominal surgeries. And also the opioid tolerant patients are the patients that could benefit from perioperative or sub-anesthetic doses of ketamine. And really the benefits for these procedures come down to decreased pain scores, decreased opioid consumptions, and even a reduction in PONV, which the decrease in PONV is largely thought to be related to the decrease in opioid use and thus the decrease in opioid related adverse events. The use of ketamine in these two patient populations received a grade B benefit, meaning that the net benefit to these patients is at least moderate. And one of the best studies to at least support this conclusion was this 2010 article from Loftus that was published in his group, that was published in Anesthesiology in 2010. And in this paper, they showed that there was a reduction in opioid consumption, which was observed 6 weeks post-operative following just an intraoperative dose of ketamine for spine surgery. So if you go back and think about the title of my presentation, the value of ketamine in the management of acute pain, this is really where ketamine gets a lot of its value. The evidence suggests that a short intraoperative course of ketamine has the potential to affect outcomes 6 weeks after surgery. In the face of the opioid epidemic, this can be this can be big. The other class of patients, or what I call sometimes the newer non-surgical classes of patients that could benefit from ketamine, include our opioid tolerant non-surgical patients, such as those undergoing with chronic pain, undergoing acute on chronic exacerbations of their painful conditions, such as the sickle cell patients, migraine patients, and even substance use disorder patients with non-operative acute pain complaints. Another population are the high-risk patient populations that are at risk for opioid-related adverse events, such as those with sleep apnea. And although the evidence in this cohort of patients is much weaker, this received a grade C recommendation. There's been several case reports and case series and even clinical experience that indicates that ketamine is still very good in reducing pain scores and possibly even opioid consumption in this cohort of patients. So when it comes to dosing, the FDA describes an anesthetic dose of ketamine in anywhere from 1 to 4.5 milligrams per kilogram. For acute pain, we use a much lower dose, hence the term sub-anesthetic or below the anesthetic dose. The guidelines state that a bolus dose of 0.35 mg per kilogram, an infusion dose of less than 1 milligram per kilogram should be used. Excuse me. As long as you stay within this range, in general, you really don't need to monitor these patients continuously with ICU level monitoring. Of course, because every patient is different and there are different with different patient variabilities in terms of pharmacokinetics and pharmacodynamics, you really should use your clinical judgment in select patients. So the only part of the ketamine guidelines that received a grade A recommendation refers to the personnel involved. The guidelines state that the supervising clinician should be a physician that's trained in ACLS and also has experience with ketamine. So this includes an anesthesiologist, an ICU doctor, or an intensivist, again, who's also ACLS certified. The administering clinician can be anyone, such as an NP or PA, or even a specially trained RN that's received specialty training in ketamine, and they also have to be ACLS certified as well. So when it comes to adverse effects and contraindications, ketamine has a pretty well-known side effect profile. Many trainings can tell us that ketamine is associated with an increase in intraocular pressure, an increase in cerebral pressure. It stimulates the sympathetic nervous system, so there's caution in patient people with cardiovascular disease. It's hepatically metabolized, so there should be caution in patients with pre-existing liver disease. And it's also not a very protein-bound drug, so it can cross the placenta very easily. So because of all these things, there's caution on patients with liver disease, pregnancy and cardiovascular disease, and also patients with psychosis. The problem is these side effects are most well known when we're using general anesthetic doses of ketamine, and it's not really well known if these are these really occur in the sub-anesthetic range of medications. Fortunately, many of these effects, they're dose dependent, and preemptive use of benzodiazepines such as Versed, lorazepam, and also alpha-2 agonists can sometimes mitigate a lot of these symptoms. So to summarize my portion, sub-anesthetic ketamine is a very powerful opioid-sparing analgesic that can be used for various surgical and non-surgical causes of acute pain. Overall, the evidence ranges anywhere from low to moderate, and the psychomimetic and cardiovascular adverse effects can be a major barrier to implementation across various institutions. Most of these effects are dose dependent, can be mitigated with preemptive use of benzos and alpha-2 adrenergic medications such as clonidine. This last slide comes from the ketamine guidelines, and thank you, everyone.
Okay, thank you, Jeff. My name is John Paul Pozek. I'm an anesthesiologist at the University of Kansas Health System. Tonight I'm going to talk about optimizing perioperative acute pain management with intravenous lidocaine. So I come from the University of Kansas Health System, which we're a very large academic institution. We're a level 1 trauma center and tertiary care center. We have a large acute pain service that's very regional anesthesia heavy. We do a lot of peripheral nerve catheters, a lot of epidurals, IV ketamine infusion, though not at the doses that they do at Thomas Jefferson University. But we also do IV lidocaine infusions in all patient care units, and that's what I'm going to be speaking about today. So, So I like to quote, sooner or later, everything old is new again. And that's certainly true with IV ketamine, but it's also true with IV lidocaine. And this is a drug that's been around since the 40s, the first amino-amide local anesthetic that was created. It has a very short half-life and a favorable safety profile. So it's really the local anesthetic of choice, the IV route. Used to be used for ventricular arrhythmias more, but it's also been used for perioperative pain control. It's been used in that capacity since the late 50s. Especially for neuropathic pain, CRPS, especially trigeminal neuralgia. And there are multiple studies that show safety and efficacy when using IV lidocaine. So it's very important that you have a serum lidocaine dose of the serum lidocaine concentration of less than 5 mics per milliliter. Going above that, you start to have the prodrome of local anesthetic toxicity, such as ring in your ears, metallic taste in your mouth, that can quickly progress to CNS excitation, CNS depression. That can progress to cardiac excitation and then cardiac collapse. So safety is very important with a lidocaine infusion. So how does this work? How does lidocaine cause analgesia? So everyone knows it affects the voltage-gated sodium channels. And these are involved in neuropathic and anti-inflammatory nociception. And lidocaine, when used intravenously, it blocks the propagation of neuropathic and anti-inflammatory pain. And this can also suppress the ectopic charges of DRG, of an injured DRG or injured peripheral nerves. But the voltage-gated sodium channels aren't the only receptors that are affected by lidocaine. There are many pharmacologic targets of lidocaine represented by this graph. Blockade of the receptors is involved in pain modulation, and many of these are being studied currently in the chronic pain world. And this is kind of outside the scope of this talk. If you're interested, I would check out the article by Hermans in British Dermal Anesthesia. Very interesting how lidocaine affects all of these ion channels. But it's not just ion channels that gives analgesic properties of IV lidocaine. It also has an anti-inflammatory effect. So not only does it decrease the priming of neutrophils, it decreases the circulating concentration of inflammatory cytokines, such as interleukin 4, 6, and tumor necrosis factors. Furthermore, IV lidocaine can modulate the p38 pathway in spinal microglia to decrease the production of pro-inflammatory cytokines, such as interleukin 1 beta, interleukin 4, and tumor necrosis factor. So there have been multiple studies in the late 2000s, early 2010 that showed benefit of IV lidocaine versus placebo, as well as non-inferiority trials comparing IV lidocaine with peripheral nerve blocks and neuraxial anesthesia. But the big study was the 2015 Cochrane review. This is a very large study that looked at 45 trials and over 2,800 patients. And what this saw is that there was statistically significant pain relief in the first 24 hours when compared with placebo. Most benefit was seen in patients getting laparoscopic abdominal surgery, although there was some benefit with open abdominal surgery as well. Decreased postoperative ileus, postoperative nausea and vomiting, perioperative opioid consumption, and decreased length of stay. And as you can see from the forest plots, open abdominal surgery, there's a clear benefit in the PACU compared with placebo. Laparoscopic abdominal surgery, the same. When it talks about other surgeries, we're talking about a mix of orthopedic, vascular, neurosurgical surgeries. Didn't really see as much benefit in the PACU. At 24 hours, there's not as much of a benefit in open abdominal surgeries, but there's still a clear benefit demonstrated with laparoscopic abdominal surgery at 24 hours. Again, not that much of a benefit in those other surgeries. And this trial was, this review, this meta-analysis gave everyone a pretty optimistic view of IV lidocaine. And there are multiple studies, and we saw more of an inclusion of IV lidocaine in ERAS protocols. And I know at our institution at KU Medical Center, we started a protocol to use IV lidocaine in all floors in the hospital, again, which I'll discuss later. But then came the same group that did the 2015 Cochrane review, updated it in 2018. And this is a larger trial. They looked at 68 trials, a larger meta-analysis. They looked at 68 trials and 4,500 patients. And this one is not as optimistic as the 2015. What they saw was decreased pain when compared to placebo. Not really a difference with different type of surgical procedures that we saw in the 2015 review. And there's likely no clinically relevant effect greater than 24 hours. So a little bit of a benefit, not as much as we saw in the 2015 Cochrane review. However, there's still a decreased length of stay, time to first flatus, and decreased postoperative nausea and vomiting. One thing that the authors did mention is there's just a lot of heterogeneity and range of surgical subspecialties and operations that were used in these different trials. There's a lot of heterogeneity in primary outcomes as well as in the assessment of bias. So there's just a big need for high quality studies in the future. And if we look at the forest plots, we can see that I'm going to refer to this as a low rate of infusion, or less than 2 milligrams per kilogram per hour of lidocaine. In the PACU, there's a benefit, but it's not statistically significant. When they use a higher rate or greater than 2 milligrams per kilogram per hour in the PACU, there's statistically significant benefit using lidocaine infusion versus placebo. At 24 hours, and those who had low rate, those just given during the procedure, again, not much of benefit. If you look at the higher rate that was just given through the procedure, you have less of a benefit at 24 hours. And those patients who received the low rate during the procedure and then 24 hours, there's a statistically significant benefit at 24 hours versus placebo. But at the high rate that was continued for 24 hours, we just don't see that. And when you look at 48 hours, pretty much across the board, there's no statistically significant benefit. This is why they say there's not much benefit after 24 hours. So a little bit of benefit, but we also see there's statistically significant decreased ileus, decreased time to first flatus, and lengthened hospital stay. So what I get from this is it's still a good medication, and it's a good thing to have in our armamentarium, especially if we can't do any peripheral nerve blocks or any neuraxial anesthesia. It's important to have this medication available to us to help make our patients more comfortable. And recently there is a study out of Ottawa that looked at their use of intravenous lidocaine over 8 years, large study that had over 400 patients. And these patients they use this after orthopedic procedures, neurosurgical, colorectal, and vascular. And what they were looking for is a clinically important difference, or a drop in the pain score of at least 2 or greater than 30% reduction in pain after 4 hours. And what they saw is when they started IV lidocaine, they saw a clinically important difference in more than half of patients that got lidocaine. I think this is especially important that they saw a similar effect in chronic pain patients. And the area where they saw the most effect was when it was used for rescue. Say their patient they were having pain that was not responding to different therapies, and it was used as rescue. They saw a big benefit with starting IV lidocaine. So something that can help, and it's a modality that we can use that has a good safety profile. And now we've been going about, just defining how to safely use IV lidocaine. And recently there was an international consensus statement released by Dr. Fu and his team. And they brought up some really good points when using intravenous lidocaine. It's important to have informed consent because IV lidocaine is an off-label use of this drug. So it's important to speak with your patient, make sure that they understand why you're using it, the benefits you think that it's going to give the patient, and also that you're using off-label. It's important to base this drug based on ideal body weight, to not have it concurrent with other local anesthetic interventions, such as wait at least 4 hours after a peripheral nerve block or wound infiltration with local anesthetic. You want to wait 4 hours after. You want to wait 4 hours after completing a lidocaine infusion before doing a peripheral nerve block. Take off all of the lidocaine patches that your patient has on. If you do want to start an epidural, they recommend waiting at least 30 minutes after stopping your lidocaine infusion before starting epidural. It's probably fine to do a spinal. It's fine to do a spinal with a lidocaine infusion since we're using such a small dose of local anesthetic. And they say that it is fine to have a concurrent ketamine infusion. In fact, they recommend it if you think it's going to be beneficial to your patient. They recommend starting the lidocaine infusion at 1.5 milligram per kilogram per hour because this is the infusion rate that's most associated with less than 5 mics per milliliter of serum lidocaine. And they recommend infusion lasts less than 24 hours as one, we don't really see a lot of benefit after 24 hours. And 2, it just takes longer there's longer clearance after 24 hours with the lidocaine infusion. So that so we know that it's safe, and this is a study out of Vanderbilt where they use lidocaine on all the patient care units, and they use it quite often. We see that 4,400 patients in the last 4 years, and so they use a standardized dosing regimen for each weight, so less than 70 kilograms based on ideal body weight. They use 1 milligram per kilogram per hour. For 70 to 100, they use 1.5 milligrams per kilogram per minute. And for greater than 100 kilos, they use 2 milligrams per kilogram per minute. So with the standardized regimen and structured patient monitoring, all these patients are seen every 4 hours and evaluated by nursing. And if there is any worry about local anesthetic toxicity, the lidocaine infusion is stopped, and both the resident and acute pain attending are paged with a callback number and their page stat. So there's a really robust monitoring regimen and a standardized dosing regimen. And with these 4,000 patients, they've only had one patient with questionable LAS with elevated serum lidocaine, although the level was 5.9 micrograms per milliliter. So we know that it's safe. We know that it can be used safely across the hospital. And at the University of Kansas Health System, we have our own IV lidocaine infusion protocol. So we do 1 to 2 milligrams per kilogram per hour based on patients' comorbidities as well as their pain level. We generally run the infusion up to 24 hours. This infusion is ordered, managed, and we bolus lidocaine, only bolused by the acute pain service. We've implemented this 2 years ago, and we've implemented this into multiple ERAS protocols, especially when patients can't get either peripheral nerve blocks or neuraxial anesthesia. And I'll take your questions afterwards. Thank you.
Let me just share my screen. That was a great talks from JP. I thought that was very interesting, and obviously those are two of the most common ones that we use is the lidocaine and ketamine. In New York, where we speak and work, we can't put them on regular floors. We have to put them in an ICU. I hope you guys could see my video okay. And I'm going to talk about some advanced multimodal analgesics for your acute pain toolbox. I practice acute and chronic pain, so I always like to see different modalities out there, especially lidocaine and ketamine over the past couple of years. We've been using in the chronic pain world for nerve pain, chronic pain, migraines, CRPS. And with the advent of the opiate crisis and also more people on medication-assisted treatment like Suboxone and different type of buprenorphine treatments, it's good to have different options in your toolbox. I have nothing relevant for this talk. I am an advisory board, ad hoc consultant, and a partner in my group. And we're going to get back into this. The first thing I'm going to talk about is dexmedetomidine. When I first started practicing, it was very expensive. We only used it in select cases. Now that the price has come down, people have found different uses for it. It's an alpha-2 agonist. The effects are mediated via inhibition of the neuropotassium and sodium channels. It blocks the hyperpolarization of the cation current. And it's interesting is you get analgesic properties, you get an antisympathetic property, and you get a sedative property by using it in a bolus form or in a infusion. For bolus, you have to watch out for hypotension and bradycardia as you use it in your practices. You do get a dose-dependent inhibition of C fibers and the alpha-alpha, which makes it useful for pain. And the other benefit, similar to ketamine, except ketamine you cannot give buccally. You can give this orally, IM, IV, even intranasal. There was one study in my references that they compared midazolam 40 to 60 minutes prior to a tonsillectomy and adenoidectomy versus intranasal dexmedetomidine 0.1 and 0.2 milligrams per kilogram. And it reduced the doses of analgesic drugs, and you got the same sedation and relaxation of midazolam. So it's another option for kids with an allergy, or if your institution doesn't have it. The biggest issue of doses of 2 mic per kilogram or greater increase the recovery from the period, so you don't want this. The other thing you also want to remember for all of these, ketamine, lidocaine, I'm going to talk about dexmedetomidine, magnesium, and esmolol, is we don't want a simple knee scope coming out of the operating room looking like a complex cardiac case. You can't transfer everyone with 2 IV poles and drips everywhere. If it's a simple non-painful case, these different infusions might not be the option. These are for difficult patients, patients where you cannot do neuraxial or any sort of regional cases, or people with different pain issues or anxiety issues. So the IV dose, 1 mic per kilogram dexmedetomidine for 10 minutes, then an infusion of 0.5 mics per kilogram, titrate up to 0.7 mics, and you're stopping about 15 minutes, starting at 15 minutes before the GI option, helps prevent opiate-induced hyperalgesia. So this is good for some of your spine cases, people on high-dose opiates, if they're on methadone or buprenorphine before. A single dose of 0.5 mics per kilogram. It decreased your intraoperative propofol, your post-op analgesic requirements. And if you're giving this as an infusion along with spinal or epidural analgesia, it did increase your sensory block by 17% and your time to first analgesic 53% when giving with neuraxial anesthesia. So it's something else to consider if you're moving to transitioning to a joint program and you're using shorter local anesthetics, and sometimes your surgeon might need a little bit extra time. This is one option. You have to be aware of bradycardia and hypotension, so be wary of your patients with cardiac issues. You do not want to have any problems. It could also be used as a nerve block adjuvant. So in a sensory onset, you got about 4 to 9 minutes faster, depending on the dose they use. You get about 1.5 to 9 hours dose dependent for your motor prolongation. And again, the hypotension or bradycardia can come back to bite you. You also had a little worse nausea and vomiting. There was a study, IV Dex with a single injection interscalene brachial plexus block for outpatient shoulder, and it decreased the pain and opiate consumption for up to 8 hours postoperatively. And this did not decrease the motor blockade, which is kind of interesting. It prolonged the block. We're always looking at different medications and options to prolong our sensory block and pain relief for our patients. They don't know the exact mechanism. They're thinking central sedative and analgesic effects, and maybe from the alpha-2 effect of the medications. Dr. Hussein and Brumet and their team and Dr. Broll gave a study of paraneural versus IV dexmedetomidine as peripheral nerve block at the systemic review. This was a pretty interesting study. They looked at 10 different studies, 7 from the upper extremity, 2 from the lower, and 1 a truncal blocks, and they dosed between 50 mics or 0.5 to 1 mic per kilo. And moderate evidence that IV dexmedetomidine is inferior compared to the paraneural dexmedetomidine. The paraneurals are brought up before. You had a longer duration of sensory motor and faster onset. Before we go over to magnesium, the other thing you have to worry about for a short case, it's not always the best option, or an outpatient case, because you have sedative effects. The benefit of dexmedetomidine, if you have a long spine case and they're going to go to the ICU after they use high dose opiates, you can continue these infusions in the post-op area or ICU, especially if you don't plan to extubate right on the table and you need to bring them to the post-op area to extubate. It's another option in your toolbox. Magnesium has come into the foray over the past decade as well. And people have looked at it because it's easily accessible. It's cheap. The side effect profile is pretty good. It's interesting, as my other 2 colleagues brought up, is that it's another NMDA antagonist, which we have limited amount that we have access to all the time. It's an analgesic adjuvant, and the calcium channel effect of it is antinociceptive and also morphine potentiator in animal models. It's an antidysrhythmic. And for anyone on the call who does OB, that's where I'm working right now, unfortunately, is we use it for seizure prophylaxis. So most staff is comfortable using it. In animal models, it inhibits hyperalgesia. And the mechanism of action, different researchers have theorized different options, and they think it's from the competitive and non-competitive NMDA antagonism from the hippocampus. and also the presynaptic calcium channel block calcium channels, and that helps regulate our aspartate and glutamate receptors. There's a study from Tramer et al. They gave a 250 milligram bolus and 500 milligrams an hour, and they found that less patients required rescue analgesia. The control required meds earlier, and they had a little bit prolonged sensory and motor blockade after spinal anesthetic. Statistically significant, not so much clinically. Advise you an extra half an hour of each. Depending on what case you want to use this for, it's something to potentially worry about. Sometimes if we have extreme varus or valgus knee for a total knee arthroplasty, at one of the places that I work, the surgeon likes to check motor right away. So that might not be the best case where you want to use it for. Different dosing regimens. This is from Rodriguez Rubio et al. And they looked at 20 different trials qualitatively, 19 quantitatively, and they used a loading dose, 30 to 50 milligrams per kilogram, then an infusion to 8 to 15 milligrams kilogram per hour. Could reduce the perioperative propofol induction dose by 28 milligrams and the maintenance infusion by 215 milligrams. Neuromuscular blockers by 3 and intraop fentanyl by 50 mics. So statistically significant, but not great clinically. 28 milligrams of propofol in adult on induction is not a big deal, I guess, unless they're a cardiac cripple. Same thing, 3 milligrams of a neuromuscular blocker or 1 ml of our standard concentration fentanyl at 50 mics is not anything to scoff at, but it is something to keep in your toolbox for those cases that go array, or you cannot do any of your other nerve blocks. Again, it has a large therapeutic window, but it does have side effects. We do need monitoring. You know, IV calcium is the antagonist. 4 to 6 milliequivalents per liter. You get nausea, vomiting. You get your tiredness, your headaches, diminished deep tendon reflexes at 6 to 10. Nausea, vomiting, lethargy, and headache, and greater than 10. That's when you get in your coma, paralysis, and respiratory failure. Could get complete heart block, QT prolongation. So be careful with your cardiac patients. The biggest issue, if you're doing this patient awake, you can see some of these side effects. If they're having a spinal or epidural under sedation or general anesthesia, you might not see this. So if you're going to run the infusion, it's worth sending labs off and checking to make sure. The last thing I'm going to speak about, and then I want to leave time for questions and just suggestions for your own practice, is esmolol. Obviously, it's an IV beta blocker. It's selective beta 1. We know it decreases the heart rate, increases our sinus cycle length, and prolongs the sinus node recovery. It helps attenuate blood pressure and heart rate secondary laryngoscopy. It's short, elimination half time around 9 minutes. The half-life is quick, 2 minutes. We've probably all used in the OR. There are a long list of contraindications: bradycardia, greater than first-degree heart block, cardiogenic shock, heart failure. You also want to be cautious with your diabetic patients and your bronchospastic disease. It does help. It decreases the post-op intensity. It reduces your intraop anesthetic and opiate requirements, and it decreases opiate-induced analgesia, less nausea and vomiting. You could bolus 0.5 to 1 milligram per kilogram. It's very well tolerated. If you're going to do it in infusion, there's a wide range, 50 mics to 250 mics per kilogram per minute. And it could decrease your volatile anesthetic requirement. Like all of these other infusions and different modalities that we have, the goal is to improve our patients' recovery, decrease their amount of pain, decrease their opiate usage. But it should not be a substitute for all of our standard treatments, whether it be nerve blocks or opiates. I see a lot of stuff on social media and everyone talking an opiate-free anesthetic. And that leads to the whole debate. Is it so bad if someone gets a little bit of opiates? Is the magnesium trial show that it decreased 50 mics of fentanyl? If you're doing a 6-level spinal fusion, 50 mics of fentanyl probably doesn't make that much of a difference. I use these 3, the beta blocker, the esmolol, magnesium, and dexmedetomidine as adjuvants when I have maybe limited other options or a hard to treat patient. I want to open this up to questions. I want to thank Azra and everyone else who were on this webinar for setting this up. There's another hot topic next month. Jaime for moderating. If anyone has any questions, this is my Twitter, my Instagram, my email. And here's my list of references. We could send them out if you need. And just like the ketamine and lidocaine, we need larger trials, more people using it, but it's definitely an option for your practice. I hope you guys enjoyed that.
I want to thank all of our speakers. We're going to go ahead and start our Q&A and discussion. And please, for all of you watching, any questions you have, or just even your experiences with some of these multimodal analgesics, please post them in the chat or the QA, and we can discuss your experiences or any of your questions with our experts here. But I'll go ahead and start off with some questions. First, for Dr. Mojica, you mentioned with ketamine some of the side effects, such as the transaminitis, the psychomimetic effects. I think, we often see a lot of transaminitis, but, what level do you really get concerned, regarding some of these side effects, whether they're the psychomimetic or the transaminitis? As far as what to do with them, do you stop it? Do you decrease the infusion? Really, how do you handle these situations?
So I think the answer to that largely comes down to how big of an increase that you're seeing. At our institution, the upper level of normal is usually around 40. And generally, anytime we see an increase greater than 5 times normal is when we consider, hey, let's see what's going on. Do we need to, what rate are we at? Does this patient have any other hepatic diseases or any other explanations for why this patient would have an increase in his ASTs or in their ALTs? In terms of what we do, generally we just monitor it. We get labs every few days, probably every three days or so if a patient is on a ketamine infusion. And we see the rate of climb. Is this a slow climb or is this a large, massive jump? And is this something that's peaking or is it still rising or plateauing? So it really all depends on the clinical context. If it continues to increase, then we'd be more inclined to stop it as opposed to slow it down or decrease the rate.
And Jeff, I have a question. In your institution, do you guys use this for outpatient or just inpatient cases? Do you limit it to all parts of the floor? Does it have to run through the acute pain service?
So ketamine is a drug that's restricted to the anesthesia and the acute pain service. So anyone that is on ketamine has to be either recommended by our acute pain service, and the titration is also restricted to us as well. It can go on any floor within our institution as long as they're regardless of monitoring.
And JP?
Same thing. We use kind of a less dose than they did at Jefferson. We do 0.1 to 0.2 milligrams per kilograms per hour of ketamine, but we do that on all floors. And I agree with Dr. Mojica. About every 3 days that we have a patient on a ketamine infusion, we check liver function tests.
Okay, so we have a question from our audience. Just someone, if you could comment really on utilizing both ketamine and dexmedetomidine in the same patient, and is there, better value in adding dexmedetomidine when using ketamine for usually, I guess, an opioid tolerant patient or a painful surgery?
Experience.
I've used it sparingly. Usually I do not use them together. It's normally in select patients. So, maybe a high dose methadone patient or someone who's on a higher dose Suboxone over 18 or on 24 milligrams that's going for a painful surgery where I could not do a nerve block and or epidural anesthetic for various reasons. Let's say then I have done both infusions, but these people are normally staying in house. It's discussed with the surgeon beforehand. We normally have a heads up in our institution if someone's like this coming in, and obviously it's a discussion of all parties. It is safe, but it requires close monitoring because obviously you can get very sedated with the combination of ketamine and dexmedetomidine. You have to watch where their blood pressure and heart rate's going to go because it's not like a standard. You don't know how it's going to react with the dosing in each patient. I've done it a handful of times, but it's not the most common thing I do. Again, I'm not walking out from any of my orthopedic or spine cases looking like a cardiac case. I like to do interventional pain and regional. My whole point was to make everything look smooth, get the patient up, moving right away. So you have to see how your institution works. In our institution, we cannot run these drips on the floor everywhere we want. They have to be in a monitored setting due to different issues within the institution and the state.
Yeah, I think, we're experienced usually dexmedetomidine, we only limit to either the units or intraoperatively. I can say from my experience, I think dexmedetomidine is a great addition intraoperatively to ketamine in opioid tolerant patients, especially patients with opioid use disorder on buprenorphine, on methadone. I will very heavily rely on dexmedetomidine in those types of patients having, major, surgery. Obviously, if it's something that I can do under just regional, I may not need that in addition, but it's always something I'm going to keep, again, in my toolbox, which is important to note in this talk. Another question I was going to ask was for Dr. Pozek, there's the evidence for lidocaine is really best for soft tissue injury. We don't see as much benefit in our bony models, such as total joint. But one population it is often used is the rib fracture population. And some of the data even suggests that the analgesia may be similar to regional anesthesia that we do. So what role would lidocaine infusions really should they have whenever you're approaching your rib fracture patients?
So whenever I approach a rib fracture, and a lot of the injury with rib fracture, there's a lot of inflammation, and we see that IV lidocaine is a pretty good anti-inflammatory drug. So whenever I have a rib fracture patient that may or not, that I cannot do a peripheral nerve block or neuraxial anesthesia, I definitely do consider either ketamine infusion or IV lidocaine infusion. For their synergistic effects and also for the anti-inflammatory mechanism of your IV lidocaine.
Yeah, I think it's a good tool to have too, especially if it's overnight, the patient comes in with rib fractures, you don't have the time or the people in-house to place a regional block, whether epidural or a paravertebral or a ESP or something. So I think it's a good thing to have. Maybe you start the lidocaine infusion overnight and put your block in the next day if needed. So just again, these are great tools to have in your toolbox for certain patient populations.
I think the most important thing, I didn't mean to cut you off. I think the most important thing that JP and Jeff, and I believe the team at Vanderbilt has, if you're going to run these infusions routinely, it's good to have standardized protocols or limit access to people running in. That prevents obviously medication errors. All of these different infusions, the ketamine, lidocaine, magnesium, dexmedetomidine, esmolol, all have side effects. So the more ways you could standardize it or limit to a select group of people to run it, the less problems you'll have. And I think Dr. Allen and Dr. Gupta's team over at Vanderbilt, I think that's how they were able to get 4,500 cases with minimal issues. So I can't emphasize that enough if you're going to bring this to your institution or start it over there.
I definitely agree. You have to have the infrastructure to manage these infusions. Dr. Mojica, there was a question about, utilizing ketamine and lidocaine and abdominal and thoracic surgery on a patient with buprenorphine, as well as IVPCA. What comment do you have on that question?
Can you repeat that? What was the patient on?
The patient is on buprenorphine and also having abdominal or thoracic surgery, and manage them on ketamine and lidocaine as well as IVPCA.
So I think that's a reasonable combination. Patients on buprenorphine are certainly opioid tolerant. The only thing I would want to know a little bit more information about is the dose of buprenorphine and the type of PCA, just because of the partial agonist effects that you would have with buprenorphine. But the lidocaine, the ketamine, great analgesic, non-opioid analgesic adjuncts for this patient population, especially because they're opioid tolerant. They just underwent what's considered a very painful surgical procedure from a thoracic and abdominal surgery standpoint. The abdominal surgery is going to interfere with their ability to breathe and their respiration. So yeah, I think this is a great combination, and something that would be a good candidate for for ketamine and lidocaine.
Yeah, I think in those patients too, the opioid use disorder with buprenorphine is maximizing all of your tools and then having, because remember, buprenorphine is gonna, if you're on a high dose of 16 or 24 milligrams, they're gonna bind to most of your receptors. So you're not gonna have much room to play with opioids, and you may not want to expose them to additional opioids given their history of opioid use disorder. So lidocaine, ketamine, all your other multimodal analgesics, and then you may have to use additional opioids, but you may not. You may be able to just use the buprenorphine and the other multimodals.
And you could do different rescue different blocks. If you can't do like an epidural, let's say it's a trauma for abdominal, you still have the option of QL rectus sheath, depending where you are. With the advent of, I don't know, hundreds of articles during the pandemic of ESP blocks, it's some other thing that you could offer these people on Suboxone. In addition, you know, it might be worth doing, let's say, an ESP and a ketamine infusion rather than a lidocaine and continue it on the floor. You have different options to play around with these Suboxone patients as well. But if you're running multiple infusions and a PCA, I might go for a monitored setting just for safety, because these people, especially what Jaime brought up, like the 24 milligram Suboxone patients for major abdominal or thoracic surgery, it's fine to run these combinations, but you might just have to escalate the care to where they have better nursing monitoring or more frequent monitoring just for safety.
Yep. Another question. I know, Dr. Pozek, you had mentioned this as far as, you know, epidural spinal, but stopping the lidocaine infusion before doing a peripheral nerve block, especially where we're doing a larger dose of local anesthetic. Is there a time frame where you might do that?
The international consensus recommended waiting at least 4 hours after stopping your IV lidocaine infusion before performing peripheral nerve block. But you know, I would take into account how much local anesthetic you're going to be using. Maybe if you're doing a high volume fascial plane block, I'd probably wait longer than that. Say you're doing an interscalene where you use 10 to 15 cc's of 0.25%. Maybe you don't need to wait that long, but so they recommend 4 hours, but I think that you can have your own risk benefit analysis based on the patient's pain and the amount of local anesthetic you're going to be using.
And a follow up on, okay, go ahead, Gary.
Oh, sorry. Do you measure serum lidocaine levels at your institution?
Not regularly. If there's any question about toxicity, then we would, but we don't regularly measure serum lidocaine levels.
And you mentioned in your talk too that, you know, the expert consensus really didn't see much benefit after 24 hours. Mm-hmm. We routinely will let it go longer. I always kind of run into this question of how long is too long. Sometimes we'll have patients, especially some of our burn patients, on for days and days and days. But I always kind of run into the question is, you know, when, you know, should we be concerned at a certain point where they've been on lidocaine for too long?
So after 24 hours, then it's a dose-based clearance instead of the 100 minutes. So I would take into account any renal or hepatic comorbidities that the patient would have, and then also how much benefit is this having for your patient. If you can't do any peripheral nerve blocks or any neuraxial anesthesia, this is all you have, lidocaine and ketamine infusions, then I would consider having it longer than 24 hours. But after 24 hours, risk versus benefit. If it seems like your patient's benefiting from it on the burn unit, and you have a pretty low dose of lidocaine infusion, I think that's perfectly fine.
And then so we talk about with ketamine, you know, a lot of the literature focuses on the opioid tolerant, but, you know, really, where should we think about using it really in our opioid naive patients, you know, as a routine medication?
So I said in 2015, patients who are having, let's say, laparoscopic surgery, they found that these patients had a lot of benefit. And really, if you're looking to decrease opioids in this opioid naive population that's coming in for laparoscopic surgery, that's a population that I would certainly use IV lidocaine.
And then another question would be kind of our traditional way of, you know, of how we learn to do anesthesia is we go in and we give, everybody our 100 mics of fentanyl. But we're learning more and more about even small doses of opioids can cause hyperalgesia, and are also way we've learned in general is when we see sympathetic markers such as tachycardia or hypertension, we think that is pain, and we usually treat that with opioids. And I think that's where I think the esmolol data is particularly interesting because we're treating those sympathetic effects really with the esmolol. So given the rate of hyperalgesia, even with small doses, and I'm not saying opioids have no place, but should we be rethinking how we do use some of these medications, especially for a lot of the surgeries which are bigger and not amenable to regional anesthesia? So I feel like, why hasn't esmolol really been utilized as much as I think it could be in a lot of our patients?
I think lack of education. I think just the standard how you were taught. You start off your induction with your 2 of Versed, 100. I had all the attendings that used to drop 250 mics of fentanyl on induction for like a lap appy, and they're breathing at a rate of 4, and we're wondering why they're not going home. I think as more cases transition to the outpatient environment and more hospital administrators are looking at throughput and length of stay and how fast people are recovering in the institutions, I do think you'll see esmolol used more for like basic cases, laryngoscopies. You don't always have to bomb people with opiates. It's cheap, it's easily accessible, there's a wide dosing range of it, and as I believe I said, that it's pretty quick. Your half-life is 2 minutes, your elimination half-life is around 9, which I think Remy is the only thing that we have that might be a little bit faster. It's out of the system, it's very well tolerated, barring like severe bradycardia, some sort of heart block, severe CHF. It's very well tolerated. We probably all use it routinely in our practice. We maybe should grab for it earlier in our cases, as it could help our patients. We're always used to teach like, oh my God, their heart rate's over 100, they're breathing greater than 24, 50 mics of fentanyl, or whatever the dose you were taught in your training.
Yeah, and I think as you look at the literature, more and more, just even small doses are that hyperalgesia. And you mentioned remifentanil too. And that's one of the biggest, offenders when it comes to hyperalgesia, but we rely on it so much. And it's, I think we really have to retrain our brains and how we're thinking about, treating the sympathetic markers intraoperatively and how we think about pain, and use a lot of these tools, more regularly instead of relying so heavily on opioids. And again, not advocating for opioid free, but utilizing opioids when it is actually necessary, not just to treat a heart rate or a blood pressure.
It shouldn't be our first line to grab through. I think that's the biggest takeaway from this talk and the different mechanism we have. You don't have to come out with 10 infusions to say you gave not a drop of fentanyl, but maybe think twice. It maybe not or whatever it is, hydromorphone, fentanyl, morphine. It just maybe you shouldn't be grabbing for it first. You have other options. Plus, obviously, you're involved with ASRA. You have your regional, your neuraxial. There's different ways to treat pain rather than grabbing for an opiate first. They're just all part of our toolbox, which I think is important to remember.
All right, just to piggyback, if I could, on what you said, the area that I really like to use esmol on is like our EGDs and our things like that. That it's really not a painful procedure. The use of esmol for an EGD or someone that may need intubation, it's not a painful procedure. If the goal is to blunt the sympathetics, you can easily do that with esmol.
Another question for you, Dr. Mojica, would be with ketamine, a lot of people, try to do intermittent bolus as compared to continuous infusion. Is there any evidence to support intermittent bolusing, to have equal or, efficacy to the continuous infusions?
Great question. And I believe there is a name of a trial that escapes me that did show that bolus plus infusion was a little bit superior than without a bolus. Can't recall the exact details of that study. If anyone can help me out.
Okay, but a bolus alone would not be as effective as that bolus with the infusion.
Correct.
The infusion.
That's correct. Yes.
Okay. Well, I think we are just about at our time, so I really want to thank everyone for being here. I want to thank everyone for submitting questions. It was a really interesting discussion. And I want to thank all our speakers for really great presentations and a discussion. And I think what's important just about this talk is we were talking about our advanced multimodal analgesics. We're always going to be relying on our acetaminophen, our NSAIDs, and our other, standard multimodals. But these multimodal analgesics are important to remember to utilize whenever, in special populations and painful surgeries or in places where you can't, in situations where you can't do regional anesthesia. So I think these are all tools you need to remember, and we need to really rethink of how continue to rethink how we're treating pain, both intraoperatively and postoperatively, and in other acute pain situations in non-surgical patients. So again, I want to thank our speakers for their presentations and the discussion, and thank all of you for watching and your participation in today's event. And I just want to remind everyone our next Hot Topics Acute Pain and Regional Anesthesia edition is April 12th. We'll be back to our normal schedule, the second Tuesday of even numbered months. And our next topic will actually be a CME credited event on sonoanatomy of the spine. And as always, it's free to all of our members. So this will conclude our program today. Again, thank you everyone for being here, and have a great night.
Thank you, everyone.
Thank you. Have a good evening.